I'm going to just share my screen, hopefully, with my slides, which I'll send to Julia and Marie, and they can make them available afterwards. So, as Marie said, I am the lead respiratory specialist pharmacist for Surrey Heartlands ICB, and I also am what's called a NICE Medicines and Prescribing Associate, so sort of a bit like a medicines and prescribing champion for NICE. That's my email on the slides as well if you ever want to sort of drop me a note and ask me any questions. So we're going to talk about asthma and the new asthma guidance tonight. So let me just, next slide. I'm going to give just a very brief background to asthma and why it's important. And what the new NICE BTS sign guidance says about asthma, the key changes, because there's some significant changes in the management of asthma and the way we think about it using preventer and reliever therapy, AIR and MART. So I'll go through what that is later. The Surrey Heartlands asthma guidelines have recently been agreed and are on Surrey PAD, which basically follow the NICE BTS sign guidance and are fairly similar to the Sussex guidance if anybody is from Sussex. We've also updated our inhaler choices, and I'll talk a bit about those. Some tips for you, hopefully, for supporting patients with asthma and their inhalers, and finally key messages and questions. Now, in respiratory, we also use lots of abbreviations in our slides. So I've put, hopefully you're familiar with them, but I've just noted a few at the bottom, like ICS for inhaled steroid, LABA, SABA, LTRA, leukotriene receptor antagonist, LAMA, long-acting muscarinic receptor antagonist, DPI, which is dry powder inhaler, and PMDI, pressurized meters dose inhaler. So let's start thinking about what is asthma. Asthma is actually surprisingly difficult to diagnose because it's quite a heterogeneous disease, usually characterized by chronic airway inflammation, and the symptoms vary over time and with intensity, and they usually include wheeze, cough, breathlessness, and chest tightness. But you can get those sort of symptoms with other respiratory diseases and problems as well. But one of the key things about asthma is the variability over time, with variable expiratory airflow limitation. Um, I hope you'll see that one of the things we shouldn't do is define asthma according to mild, moderate, or severe usually, because even in somebody with what we think of as mild asthma, not on intensive treatment, they can have a very serious asthma attack. So why is it so important for us to prevent asthma attacks? One of the things is that people die of asthma, and people still die of asthma now, even though we've got good treatments for it. Um, Lots of asthma deaths are still preventable. And we know that patients with serious outcomes were defined as having mild asthma with few symptoms in the preceding 3 months. Yet a lot of those ended up with near fatal asthma or asthma deaths. So we want to prevent deaths, reduce the risk of asthma attacks, because every time somebody has a asthma attack, if they have a severe attack, it can start to damage the airways. And if people have quite a lot of asthma attacks over time, you can lose lung function and get longer term different sort of lung diseases like COPD. The other thing with respiratory disease and asthma is we treat the exacerbations with oral corticosteroids. Now, oral corticosteroids have quite serious side effects, and we know that even after only 4 to 5 courses of oral steroids from an asthma attack, it starts to increase your lifetime risk of some of the more serious side effects from the steroids. So it's really important that we minimize the risk of severe exacerbations because we want to reduce that harm. So this is looking at our age standardized mortality from asthma in the UK compared to other European countries. And the very sad and bad news is that the UK has some of the worst asthma mortality in Europe. So we really need to do something to prevent this and get our asthma outcomes improved. the challenge is we haven't done very well over time. So there was a big national report called the National Review of Asthma Deaths published in 2014, which estimated that about two-thirds of the asthma deaths in this country are preventable, but we still have high rates of asthma mortality. So hence the importance of looking at what are the guidelines saying and how can we improve asthma care. So the really big change in our new asthma guidelines is we are moving away from an inhaled corticosteroid plus SABA reliever regime to a combined preventer and reliever regime all in one inhaler. So the traditional way we used to treat asthma was patients on an ICS maintenance with a SABA reliever. Now, the new guidance is recommending that in all adults and children over 12 and some younger children, that they should be treated with a ICS formoterol inhaler, either as a maintenance and reliever treatment, or if it's they're not very symptomatic, something called an anti-inflammatory reliever as needed treatment. So this is a key change. The thing about formoterol is it's a really useful long-acting bronchodilator because it works very quickly as salbutamol, but it also works for a long period of time. So it's sort of you're getting a double benefit. You're getting both what the benefit you might have got of a reliever or a short-acting bronchodilator, and also the benefit of it lasting for a long period of time. So the terms air and mart you'll hear used in the context of asthma treatment. And basically, this is a preventer and reliever two-in-one inhaler using low or moderate dose inhaled corticosteroid plus formoterol. So other long-acting bronchodilators are not suitable for this air and mart treatment because they don't work as quickly as formoterol. Most of the air and mart inhalers contain budesonide. There are a small number that also contain beclometasone, but they're only licensed in over 18s. So AIR, it stands for anti-inflammatory reliever, and this is a low-dose ICS formoterol inhaler, and it's used as needed in response to mild and infrequent asthma symptoms, and you don't need to take it regularly. So it's only for a small proportion of asthmatics, but if they've got mild and infrequent symptoms, it works very well. They're licensed from 12 years and over. They're not recommended at all in under 12s, and no SABA, salbutamol inhaler, is needed as a reliever with this treatment because the formoterol does that job for you. And there are specific patient action plans for this AIR regime that those patients should have. Now, MART stands for maintenance and reliever therapy, and that is low dose ICS formoterol and moderate dose ICS formoterol. And this regime is used for patients who are more regularly symptomatic with their asthma symptoms, so they need daily treatment, maintenance treatment for their asthma, but also they use their ICS formoterol inhaler as a reliever in response to symptoms as well. Again, they're all licensed from 12 years and over, and in some children they are recommended to be used, even though at the moment they're not yet licensed for children under 12. Similarly, no SABA reliever is needed in these patients. There is a recommendation, though, that particularly in under 12s, if there's a concern that patients can't use their dry powder inhaler because they're all dry powder inhalers during an acute asthma attack, then they should consider having a salbutamol inhaler plus spacer at home, but that's only a small proportion of patients. And there is a MART specific action plan. So we have patient asthma action plans specific for each regime. You might wonder, oh, well, are we worried about giving patients too much inhaled corticosteroid? But all the clinical trials with these regimes found that patients on average needed to use fewer reliever doses, maybe only 3 to 4 doses per week, and actually the overall dose of inhaled corticosteroid the patients needed to take was lower than if they were on a regular maintenance regime. They can be used pre-exercise, just as you would a salbutamol inhaler, and there isn't a need to rinse the mouth after a PRN dose. So why did NICE and the new guidance recommend using these air and MART regimes? And the key reason really is that the outcomes with these regimes are better than our traditional ICS plus SABA reliever pathway. They are better at reducing exacerbations and improving symptom control. It's also good for patients. It's simple. It's one inhaler for both prevention and relief. And if they're paying prescription charge, it's only one prescription charge. They're dry powder inhaler regimes, so obviously better for the environment because we're not using pressurized metered dose inhalers. They're also very useful in patients where compliance isn't very good, uh, and regular daily dosing is a problem because they also, every time they use their inhaler as a reliever, they're getting some extra inhaled corticosteroid. Now, that's particularly good because in asthma, we know adherence is not very good to inhaled corticosteroids. It's probably about 50% adherence at best, and in some studies, adherence is as low as 20%. So you can sort of see why this type of regime using inhaled steroid with the formoterol as a reliever seems to be a good thing because it's making sure patients get their preventative inhaled corticosteroid. And as I've said, it's also safer because patients generally need a lower dose of inhaled corticosteroid on these regimes and can be used pre-exercise just like a SABA. So another reason why these regimes are recommended now is that we know in asthmatics overuse of SABA inhalers, whether their patients are on an ICS as well or it's a SABA alone, is not good for patient outcomes. So NICE guidance now says do not prescribe a SABA alone for any patients of any age with asthma without an inhaled corticosteroid. And that's a really strong message from NICE. So what's the issue here? We know patients tend to over-rely on SABA inhalers. It's usually the first inhaler they're given and told to use whenever they have symptoms. So they see it as a really useful inhaler because it makes them feel better immediately, gives them symptom relief. And even patients without good technique, because you get buccal absorption of the salbutamol, you still can get some into the system. It has a rapid onset of action, it's convenient, patients take it around. But as we've said, we know that less than 50% of asthmatics take their inhaled corticosteroid as intended. So patients tend to overuse their SABA inhalers. What we also know is that overuse of SABA inhalers is associated with increased morbidity and risk of death in asthmatics, especially if they're not using the inhaled corticosteroid to prevent inflammation. So overuse of SABA is a sign of can be a sign of uncontrolled asthma or underuse of inhaled steroid. And the more SABA one uses, the higher the risk of an adverse outcome, so including death. So if somebody's using like 20 or so SABAs, that's worse than if they're only using maybe 3 excess SABAs, the risk goes up. What we also know is that using a lot of SABA creates some sort of vicious circle. So you actually, when you have a lot of salbutamol, increase your airways hyperresponsiveness. You get reduced bronchoprotection because you get receptor tolerance. So you get a reduced bronchodilator response. So it's sort of a bit of a vicious circle. The other thing that NICE says is that for children and young people, over and adults over, sorry, for adults over 12 and over 12s on aeromart therapy, they don't need to be prescribed a SABA reliever inhaler because then if they were prescribed a SABA, then it wouldn't be a air or MART regime. As the patient's already using a SABA and moving over to air and MART, it should be okay with good counselling to discontinue the SABA at that time, then move to air or MART. But if patients are really strongly dependent, psychologically dependent on their SABA, then maybe a phased withdrawal over 3 months would work for them. So the Surrey Heartland's asthma pathway is based on the NICE BTS sign guidance, which was published at the end of November last year. And we have two pathways, one for adults and children from 12 years of age and for children aged 5 to 11 years old. The NICE guidance also has a pathway for under fives, which we are working on at the moment. So this is our local pathway, which is based very strongly on the NICE pathway and has just been approved by the Area Prescribing Committee and is on the Surrey pad, with which I hope you're all familiar, but the hyperlink was in the previous slide. So what the recommendation now is in newly diagnosed asthma patients is, depending on the level of symptoms, whether they're mild and infrequent or more symptomatic, we start the patient on the low dose ICS formoterol inhaler, either as an air regime taken as needed for symptom relief, or if patients are more symptomatic, taking it regularly as a maintenance and reliever treatment and using that inhaler as a reliever as well. If patients are more symptomatic, then we move up to a higher dose of inhaled corticosteroid in the MART inhaler to take as maintenance and reliever therapy. Always at each step of the pathway, checking patients' control, their inhaler technique, is the diagnosis right, are the trigger factors, which are really important to identify an asthma, eliminated, and patients' inhaler technique. Now, if asthma is uncontrolled despite good adherence, we're, if possible, looking for markers of inflammation, because in asthma, the inhaled corticosteroid should hopefully reduce the level of inflammation, which we can measure using something called exhaled nitric oxide, or FeNO, or if that's available, or we can also do a blood test looking for blood eosinophils. If those aren't raised and people are still symptomatic, we can add in a third treatment, which would be, depending on the type of symptoms the patient has, montelukast, which is particularly useful in patients with allergic rhinitis, or inhaled long-acting muscarinic antagonist, and the only one that's licensed is Spiriva Respimat. And either of those for a 3-month trial to see if they help symptoms. And if they don't, you can always swap to the other one. But if inflammation hasn't been reduced at an earlier stage, or if the asthma is still uncontrolled, then patients should be referred to an asthma specialist. So this part of the pathway is a complete change. So we're moving straight into an ICS formoterol inhaler. We're not starting with an ICS SABA regime. The other thing that's very different with the guidance is that there's quite a strong recommendation to change uncontrolled asthmatics who are on the traditional regimes onto an air or MART regime, depending on what they were on before. So NICE are recommending uncontrolled asthma, particularly if they're on inhaled corticosteroid plus a SABA, onto some sort of MART regime. And any patient who's on a high dose inhaled corticosteroid based regime whose asthma is not controlled should be referred to a specialist in asthma care. So that's the sort of fundamentals of the pathway. Asthma is considered poorly controlled in any patient requiring an exacerbation needing oral steroids, if they have symptoms requiring reliever dose 3 or more times a week, or if they're waking at night once or more a week. That's just the highlighting for patients on existing treatment what to do if they're not controlled. And with the recent advice from the MHRA about salbutamol SABA inhalers and asthmatics alone on it, regardless of their level of asthma control, any patient on a SABA alone should be changed to a low-dose ICS formoterol as an anti-inflammatory reliever regime taken as required for symptoms. So that's the pathway. What inhalers should we using to treat asthma in that pathway? Now, there are only 4 inhalers licensed for air and MART. They're all DPIs containing budesonide and formoterol. We've recommended 3 of the licensed inhalers in Surrey Heartlands, the cost-effective choice being Fobumix Easyhaler, which is the least expensive of the 3 on our formulary, and that's the same as Sussex, if anybody's from Sussex. For patients who maybe aren't comfortable using the Easyhaler device, then there's also Symbicort Turbohaler and Duress Spiromax. Now, the strength of inhaler is quite important because only the 164.5 of the Duresp and the Fobumix and the 206 of the Symbicort Turbohaler are licensed for air and MART. And this is really important to get the strength right because it's also important in terms of the number of reliever doses that are recommended, maximum number of reliever puffs, and the maximum number of puffs in 24 hours, so that we don't end up giving the patients too much ICS or formoterol. So this is taken straight off the guidance on Surrey Pad. So an air regime is 1 puff as needed, and then the reliever dose is 1 puff as needed, with a maximum number of reliever puffs of 6 per day and 8 in 24, sorry, 6 in relievers and 8 in 24 hours usually. Now, the good thing is that all these have the same dosing instruction, which makes it a bit easier. So low dose MART is usually 1 puff twice a day. Moderate dose MART is 2 puffs twice a day and 1 puff as needed reliever. The maximum number of reliever puffs for these is 6 a day, but if they're already on a moderate dose MART, we have to be careful because they're already on 4 puffs a day, and we don't really want to go above the maximum of 8 puffs a day. So we usually reduce the number of reliever puffs to 4. So they're the preferred inhalers. They're all dry powder inhalers, which is good for the environment, and they all have dose counters. For adults and over 18s, we have an additional choice only for patients who need a low dose MART regime, so it can't be used as first line. Air regime would be a Foster Nexthaler, which is a useful device, or the as an alternative to Foster, there is a newer, less expensive alternative called Proxor, which is exactly equivalent to Foster, which we're now recommending instead of Foster pressurized metered dose inhaler. And this is also similar to Sussex, whose first line beclometasone ICS formoterol inhaler is Bibecvo. And similarly, so the dosing is here that for the asthma recommended MART regimes, the only dose you can give is low dose MART, 1 puff twice a day, because they are quite high potency inhalers and more potent per puff than the budesonide containing inhalers. They're not licensed for moderate dose MART, so it's 1 puff twice a day. So there are some patients that are more suitable for air and MART and some patients who are less suitable. So if we're thinking of particularly uncontrolled patients and switching them over to the new regime, um, it, obviously we want to make sure that they've got an asthma diagnosis, but anybody with poor adherence or forgetting to take their inhalers would be an ideal candidate for air or MART. But the patient needs to be able to recognize their symptoms and act on them, so know when to take a reliever puff. If Patients are confused about reliever and preventer inhalers. Again, having a 2-in-1 inhaler is really useful. If they are on a metered dose inhaler and have poor inhaler technique, moving to a dry powder inhaler, which is easier to use and doesn't need a spacer, is also could be an advantage. For patients having frequent asthma attacks and whose asthma is not very well controlled, MART regimes are really useful because we know from the studies that when patients with asthma start to before an attack, a severe attack comes on, they tend to start using their reliever inhaler more and more and more in the days leading up to it. So by using a MART inhaler that has an anti-inflammatory as well as their reliever, and they're using that more and more as they get symptoms prior to a severe exacerbation, you're giving them the steroid really early on to attack the inflammation. And we found that it reduces the risk of severe exacerbations, which is one of the reasons why it's so useful. The as needed anti-inflammatory reliever is particularly useful in patients with seasonal symptoms. So you can step up and down as required if they tend to only get asthma in the hay fever season, for example. And any patients who are overusing and overordering their SABA inhalers because of the risks we've outlined would also be extremely good candidates for the air or MART regime. But air mart is not for everybody, and there will be some patients where we would need to stick with the traditional regime. So, for example, if a patient was really unable to recognize their symptoms or didn't have the capacity to use a reliever inhaler when they needed it and need someone else to make that decision, so it might be um, an elderly person with cognitive impairment or somebody with a learning disability, somebody who was unable to understand their asthma plan about when to take a reliever and what to do. So it might be a language barrier or again a disability. If we weren't sure of the diagnosis, then we wouldn't be using this sort of regime. Or if they couldn't use a dry powder inhaler, so it might be in younger children or frail elderly, um, where they would need to use a metered dose inhaler with a spacer, so they were unable to load and prime the device. So that's Air and Mart in a nutshell, and why we're moving towards it. So what does the guidance say for younger patients, for our age 5 to 11 years old? Now, the pathway has changed a bit, but not completely. So what the guidance says now is for newly diagnosed children, age 5 to 11, we would usually start on a traditional regime of a low dose regular inhaled corticosteroid on its own with a SABA inhaler as symptom relief. However, if in those patients the asthma remained uncontrolled, we should consider whether the, the patient is able, the child is able to manage a MART regime. And thinking about some of the factors we've just discussed would be quite important for that to consider there. In the randomized controlled trials where they have trialed MART in children, they actually use them down to age 6, which is quite ambitious. And most of the specialists you will talk to will suggest that you can start to use a dry powder MART regime in older primary school children. So what the guidance recommends is if the asthma is uncontrolled on a traditional low dose in steroid plus SABA, that we would assess the ability to manage a MART regime. And if children could manage a MART regime, then we would use a pediatric low dose inhaled corticosteroid formoterol treatment as maintenance and reliever therapy. We don't use the anti-inflammatory reliever therapy in children at the moment, and then escalate to moderate dose if asthma remained uncontrolled, and then refer to specialist. So in children who couldn't manage a MART regime, then we would increase to a trial of Montelukast, 3-month trial, and if that didn't work, then we would increase to a pediatric low-dose inhaled corticosteroid with a long-acting bronchodilator included, and then step up. So, in terms of our preferred inhalers for the children's pathway, the inhaled corticosteroid containing inhalers would be, for a dry powder inhaler, it would be a budesonide Easyhaler or a Pulmicort Turbohaler. And for a metered dose inhaler, it would be good old Clenil Modulate, because we use that lots and it works perfectly well with a spacer. Our SABA containing inhalers, for a metered dose inhaler, it would be Salamol plus a spacer. Otherwise, it would be, if they can use a dry powder inhaler, the cost-effective choice is an Easyhaler, salbutamol, or Ventolin Accuhaler. And then for ICS LABA containing inhalers in children that are licensed for pediatric low-dose ICS, dry powder inhalers would be the low-dose Fobumix Easyhaler or Symbicort Turbohaler. Or if children needed an ICS plus a LABA, then we still have low-strength Flutiform or Seretide Evohaler available for them. Now, one of the things to note about using MART inhalers in children and age 5 to 11 is that none of them are currently licensed. So it would be off-label use of these inhalers, but we could use Fobumix Easyhaler 84.5 or Symbicort Turbohaler 106 we could use, and there's the dose regime there. Now, there isn't a published dose regime for MART and the maximum number of reliever puffs and doses in children. So, but there are clinical trials going on at the moment, led by national pediatric respiratory specialists, and the recommended doses here are from the national consensus of pediatric specialists. So you won't see this in an SPC. In very rare circumstances, then the Symbicort metered dose inhaler 103 with a spacer might be used for a MART regime, but only in rare circumstances. The other thing we've done is we've made recommendations around which spacers to use, and we're recommending for most patients the Aerochamber plus FlowView range of spacers, plus of course keeping the volumatic and volumatic pediatric. So just a word about using inhalers off-label in children and young people, because some healthcare professionals can feel a little bit uncomfortable about that, where we're recommending this. Now, it's, as we know, a lot of medicines are used off-label in children, and NICE have reassured us that where prescribing is in the best interest, they will recommend off-label use where there's good evidence or experience to support that recommendation. And that is where we are with the use of MART inhalers in children and young people in under 12s. So obviously healthcare professionals should follow relevant professional guidance, and understand that the risks actually for off-label use of MART inhalers in younger children it's very low risk, because there is good randomized control trial evidence to support it. It just hasn't got a license yet. Important to consider the need to provide information about off-label use, because obviously the patient information leaflet doesn't contain information about use in pediatrics, and making sure that an appropriate action plan is available, and there are children-specific MART action plans available. Surrey Heartlands is actually, we are in the process of developing a specific information sheet for parents about off-label use of inhalers in March, and we'll be providing that shortly. It's just going through a final approval process, just in terms of reassuring parents. So are there any no questions up to that stage? Sorry, it was a little bit dry, but so As part of our review of the asthma guidelines, we also made some changes to our formulary status of inhalers. Now, there's quite a long list, and the update will be going on to Surrey Pad, and it will take a few months for the implementation to filter down through primary care and secondary care. But some important things for you to be aware of in terms of changes and also what you might think about stocking. So for SABA inhalers, for metered dose inhalers, we've actually suggested that Ventolin Evohaler is not for initiation in new patients now, because it has a higher carbon footprint than Salamol, and Salamol is perfectly acceptable as a metered dose inhaler. And then we're recommending dry powder inhalers where needed: Easyhaler, Salbutamol, Ventolin Accuhaler, or Bricanyl Turbohaler. The inhaled corticosteroid single constituent inhalers for new patients are not recommended in adults usually, because they're not recommended for treatment of asthma in adults anymore. Only single constituent ICS inhalers for initiation in children are still green on the formulary, and the main one is Clenomodulate. We're suggesting that long-acting bronchodilator inhalers as single constituent inhalers are non-formulary, not for initiation in new patients, because there's no place for them in therapy in the management of asthma or COPD anymore. For our single constituent LAMA inhalers, we are recommending that Spiriva HandiHaler is now non-formulary, not for initiation in new patients, because there are other LAMAs available that are perfectly good, and Spiriva HandiHaler is not cost effective. It costs quite a bit more than the others. As I said, we're recommending the Aero Chamber plus FlowView group of spacers as our preferred spacers, because they are much easier to prescribe in terms of prescribers knowing what to prescribe for different age groups. And a wider range of sizes, which is better for patients. In terms of our inhaled corticosteroid LABA inhalers, our preferred dry powder inhaler for air and MART, as you saw, was Fobumix Easyhaler, but we also have Symbicort Turbohaler and Duress Spiromax available. But Fobumix Easyhaler and then Symbicort are probably the most preferred among clinicians. We are moving away from Foster metered dose inhaler for ICS LABA, so that's recommended not for initiation in new patients, and where that sort of beclomethasone formoterol inhaler is required, then the suitable inhaler would be Proxol. And we're again saying not for initiation in new patients for most fluticasone salmeterol inhalers. We are keeping Foster Nexhaler on the formulary though, just to reiterate that. It's only the metered dose inhaler. All high strength containing inhaled corticosteroid inhalers are now on the recommendation of a specialist in asthma care for new patients, because there is no place in the new pathways for high dose inhaled corticosteroid containing inhalers. And finally, we've added a couple of triple therapy inhalers for specialist initiation in asthma, which are the Trimbo inhalers to both strengths and Enerzair Breezehaler. So you might see those. Okay, so that's the inhaler pathway, our inhaler choices. Now let's think about some of the practicalities and a bit more of what we see in practice. So I thought it would be useful to share with you some of the errors we've seen with inhalers recently when we've been looking at prescribing, because hopefully you'll pick these up too. So I've got patients A to F here, and I've noted all their inhalers on repeat. All these patients were in the notes coded as being on the MART pathway. I put the dose up for all those patients. Can you tell me which of these patients is on MART and which ones aren't? You can put your answers in the chat or put your hand up. Any thoughts? Deadly silence. Give you a minute or two to read. So if you were presented with these in a dispensary and a patient said they were on a MART regime, which one would you say, oh yes? And which one would you say, we need to talk about that? Any suggestions?
In the chat, we've had patient B.
Patient B. Patient B, yeah, and somebody else is typing. Not typing. So patient B is correct. That is the only one of these regimes that is a MART regime. So they're on a MART licensed inhaler. The dose is twice a day and one dose as a reliever when required, and they put the maximum dose. What's quite scary is that all the other patients, A, C, D, E, and F, were coded in the notes as being on a MART regime, but they weren't on a MART regime because they were all using salbutamol as a reliever inhaler, or F didn't have salbutamol as a reliever inhaler, but didn't have any reliever inhaler regime. So that needed following up. And E, seretide is a fluticasone salmeterol inhaler, which isn't suitable for a MART regime because salmeterol is not a fast-acting, long-acting bronchodilator. So there's a lot of education I think we need to do, and checking out with clinicians in our GP practice is to make sure they are familiar with what is air and MART and which inhalers are suitable. So this is just one example from one practice that shall remain anonymised. The other thing we often see is duplication of inhalers prescribed together, and it's quite easily done when patients' inhaler regimes are changed, that sometimes they forget to stop one, take it off repeat, or not recognize what is the ingredient in the inhaler, what's the active ingredient. There are about 155 plus different inhalers available, so it's very confusing. And we also, of course, recommend prescribing by brand name to make sure the patient gets the right device. But we do know and do see from time to time that there's quite a bit of duplication. So we've put this on Surrey Pad, which is a Know Your Inhalers Aid memoir, which just shows where some of the overlap is and potential for duplication with the most commonly prescribed inhalers in Surrey Heartlands. It's not everything on there, but the most commonly prescribed ones, because we do see that as a problem. So please do, if you don't assume when you see a prescription for a patient for an inhaler and it duplicates. They might be prescribed a triple therapy, but they're already on a ICS LABA inhaler, for example. That's quite a common one. Don't assume that that is intentional, because we do know that there is a lot of confusion in practices and it's often unintentional. So please do just double check. So thinking about some tips for you for supporting your asthma patients, what does all this mean in terms of what things can you take back in community pharmacy? The thinking about the pharmacy quality scheme and some of the targets for the respiratory targets for this year, which one of them is around spacers in children and young people aged 5 to 15. So by age 5, most children should be able to use a spacer plus a mouthpiece. And what we it's you don't get such good technique and drug absorption using a mouthpiece, and also there's a more risk of skin side effects because of using a face mask rather than a mouthpiece. So do check if you're seeing sort of like 10-year-olds using a spacer plus a face mask. Really, do they need a face mask? Are they capable of using a spacer plus a mouthpiece? By which time they may all be already possibly be suitable for DPI. So we only recommend using a spacer with a face mask in older children and adults, in fact, when the patient is assessed as being unable to use a spacer with a mouthpiece. And we've seen adults on a spacer with a face mask and they don't need a face mask. They're perfectly capable of using a mouthpiece. So sometimes I think there's just not the right amount of thought goes into choosing what's required, or there might be some confusion about what they're picking on the list on their systems. So also in the pharmacy quality scheme, thinking about patients using salbutamol inhalers and using a lot of them and not on an ICS in 6 months. I hope you realise that how important that is, because these patients are at risk of worse outcomes. And really excess SABA use is not good, because not only is it associated with poor disease control, but it's like a vicious circle, because too much SABA means it doesn't work as well in the first place for lots of reasons. So think about, is it poor adherence or an over-ordering problem? Because sometimes it can be an over-ordering problem. Please be aware of the drug safety update that was published about a month and a half ago around SABA overuse and concerns around that in asthmatics, which again re-emphasizes the nice recommendation about not using SABA in any patient with asthma without an inhaled corticosteroid. And trying to understand why a patient's overusing SABA. Can you have a conversation with them to understand what the issue is, understand and address their concerns perhaps? So maybe some things to say to patients on SABAs. I know you need to refer them back, overusing SABAs, refer them back to the GP practice, but some good things about not using a SABA and moving on to probably an air or MART regime. SABA metered dose inhalers are significantly contributing to our carbon footprint. So about 50% of all metered dose inhalers prescribed locally and nationally at least are SABA metered dose inhalers. So it's a really big contribution to our carbon footprint. So it's not good for the environment. Using air and MART is much better for the environment. Using air and MART is safer in terms of inhaled corticosteroid dosage, because we know from the studies patients can use lower doses of ICS. We also know air and MART are more effective and safer in terms of outcomes and reduced risk of exacerbations. And it's just one inhaler to carry around, one prescription charge. So there's lots of benefits to it. Oh, finally, a quick word about dose counters as well. We know that there's been some concerns and safety concerns around inhalers that don't have dose counters because patients don't know when they run out. But all SABA MDIs don't have dose counters, and a few other steroids, ICS inhalers alone also don't have dose counters. So there's a risk of using them when empty. So we need to make sure patients are aware of when they might be empty. Dry powder inhalers all have dose counters, which is great, but check the patient can read, understand the dose counter, because some of them are quite small and not easy to read. Thinking about the new medicine service, you may hopefully be getting more referrals for the new medicine service as patients are changed to air and MART regimes from their current inhaler regimes. Important to remember about inhaler technique, the difference in technique between metered dose inhalers and dry powder inhalers. The metered dose inhaler requiring coordination and the slow and steady breathing over 3 to 5 seconds, and dry powder inhalers, which quick and deep inhalation to activate the inhaler. No need, shouldn't be shaken. Don't turn them upside down in case the powder falls out. And they have those counters. So just important to recognize that. And I can't emphasize strongly enough the importance of good inhaler technique, because poor inhaler technique is associated with worse outcomes in patients with asthma and COPD. Um, and depending on the study, up to 90% of patients show poor inhaler technique, which is actually quite shocking. So it's really important that we support patients with their inhaler technique. And there's also one or two studies that show that healthcare professionals themselves aren't always good at knowing how to use inhalers properly. So I've linked to a couple of resources there if you're not familiar with them already. There's the UK Inhalers Standards, competency standards for inhalers that you can go through to check out your competency around teaching inhaler technique. And of course, very useful resources around inhalers on Right Breathe, which you can look up lots of things about inhalers and have videos for inhaler technique on there for each inhaler. And Asthma UK has a really, really good website with really good inhaler technique videos, which are the ones that are usually patients given the link to or the QR code to access. But a couple of other points about inhalers, it's ideally don't mix inhaler types, different inhaler types with different techniques for patients. So it's really not logical to give patient a dry powder inhaler for their preventative inhaled corticosteroid and then keep them on a metered dose inhaler, salbutamol inhaler. Different techniques, it's confusing for patients, and we know from studies that different inhaler techniques uh, for, for a patient having two inhalers is more confusing and they tend to get it wrong more frequently. And we also know it's a bit like driving a car. It's really important to keep rechecking our technique and retrain ourselves, and we become a little bit unconscious unconscious competence and get a bit lax on inhaler technique. We have to keep checking that patients are using them properly and not lapsing into bad habits. So just to finish off with key messages, no SABA alone for any patient with asthma, because SABA use without inhaled corticosteroid or SABA use, excess SABA use, it increases the risk of asthma deaths. The air and MART ICS formoterol containing inhalers have been shown to improve outcomes in asthma. So they're a great way to improve asthma care in over 12s and also in some the MART regime in some children. Correct inhaler technique is really important. It's really important we can do whatever we can when we can to support patients to use their inhalers correctly. We do see quite a lot of errors in prescribing of inhalers, both in duplication and knowing what's licensed and suitable for air and MART. It's complicated, so become familiar with the inhalers and the dose regimes for air and MART. We need to understand patients' concerns when they're over-reliant on SABA inhalers and try and address those concerns and help them to not be psychologically dependent on SABA inhalers. And also in asthma, it's really important to ensure all patients have an appropriate personalised asthma action plan so they know what to do when their asthma is getting worse. Okay, and that's it. Just questions.